assisting.
Just earlier. There's all the people on it.
Oh, are we on?
I can hear you, sir.
Hi, Senator Kirshen. We can hear you.
Okay.
The meeting has not started yet.
Okay. Good.
So I literally just turned it on. They didn't hear anything.
Everybody hear me all right?
I can hear you.
Okay.
Yes.
All right, I'm just looking. I got multiple people sending me different emails here, and as soon as I can, there it is. I'm looking for the agenda. All right. Does everybody have the backup sheets, legislators? Dan, did you get them? All right. Am I muted again?
Nope, we can hear you, Senator.
Megan, Dan, did you get the backup? Senator Kirshen? Dan, can you unmute yourself, please?
I have the budget. I don't have anything else.
Well, I usually just, I'm the one that gets the agenda. I'll try to send that to you when we get started here. Senator Kirshen, did you get the backup?
No.
All right, hang on, everybody. Give me a couple minutes. Megan, you're on?
I'm on.
Okay. All right, Dan, I just sent it to you.
All right. Thanks.
Yeah. It's pretty long too, so either have lots of paper in your printer or just go off of the computer, I guess. All right, I think we'll get started. Megan, you are up first. You'd like to begin your overview? And everybody, and first off, everybody, welcome to the committee of the Kansas Department of Health and Environment. And today we'll be focused on health aspect of that in today's budget overview. So hope everybody is staying warm and safe. And is there any other questions or comments from the committee before we begin? I want to make sure we're all on. I know Senator Sollentrop couldn't join us today. Megan, do you have anything else to add, or are you just ready to get started?
No, I'm ready when you are.
And Robin, are we good with the public?
We are, Senator. Yes, we are on YouTube and you're ready to go.
Okay, thank you. Go ahead and begin the budget overview, Megan.
All right. Can everyone hear me all right?
Yes.
Yeah.
All right. I'm Megan Leopold with Legislative Research Department. I'll be doing a brief overview of the KDHE Health and Healthcare Finance budget. I'm working from the PDF that's called KDHE Budget Analysis or Budget Overview. Like the senator said, it's very long, so I will try to announce page numbers as I go along. I'm going to go ahead and start on page 39. At the top, you'll see fiscal year 2021, current year. The top of page 39 outlines the adjustments that were made to the approved budget. That's the budget that was approved by the 2020 legislature. In the bullets, you can see that there was an increase of 128.6 million. Those were funds that were reappropriated from fiscal year 20 to fiscal year 21. In the next bullet, you'll see that much of that was allotted by the governor in the July allotments. The allotment was a total of 97.1 million. A lot of that was due to the fact that the April 2020 caseloads were not adopted by the 2020 legislature. And so the savings that was associated with that Fmap increase that was calculated into the April caseloads was not in the 2020 approved number. So that was much of what made up those allotments. And I'll go over those in more detail here in a minute. There's an increase of about $13,000 that was SGF expenditures replaced with coronavirus relief funds. And then finally, there was a decrease of 17.5 million. And those were the funds that were budgeted for Medicaid expansion, that when Medicaid expansion was not passed by the 2020 legislature, were moved to the coronavirus relief fund. So at the bottom of that page under the table, you'll see that the agency requested a revised estimate of $3.6 billion. That includes 853 million state general funds. This is an all funds decrease of 469 million and an SGF increase of 22 million. Moving to the next page, page 40. The all funds decrease is largely because the approved amount still included those federal funds that were associated with Medicaid expansion, but the agency's requested budget did not. So that made a significant decrease in the all funds. That was also offset by increased funds that came in for COVID relief in the Department of Public Health. The SGF increase is largely due to the supplemental requests that the agency requested, and I'll go over those in detail as well. The revised estimate includes 1,598 full-time positions. This is an increase of 98.6 full-time positions above the number that was approved by the 2020 legislature. The adjusted positions include additional epidemiologic and information system surveillance staff. And that's in the Bureau of Epidemiology and Public Health Informatics, laboratory staff in the Division of Environment, and the Division of Healthcare Finance had some added auditors and managed care organization analysts in the Managed Care Bureau. So the second half of the page, the bullets outline the budget by category. You can see that there was an SGF decrease in salaries and wages. That was largely because that was largely due to some money that was reappropriated from 2020 into 2021, and then was offset by increased salaries and wages for new staff. Contractual services, there's an all funds decrease of 11.8 million. Most of that came from the Department of Healthcare Finance, where there were some decreased expenditures for contracts that were associated with a state employee health plan, which was moved to the Department of Administration with the ERO last year. There are also a decrease in expenditures for the Kansas Eligibility Enforcement System, or KEYS. And that was due to funds that were budgeted under KDHE that were moved to other agencies. And then, of course, those contractual services those decreases were offset by increased funds that came into the state for COVID relief. In the categories of commodities, capital outlay, and aid to local units, in each of those, you'll see a pretty significant all funds increase. And in each of those cases, it's due to funds that came in from the federal government for COVID relief. These included hospital preparedness, laboratory equipment, and supplies, among other things. In the other assistance category, you'll see that there is a state general fund increase of 7.5 million. And that's largely due to the agency's supplemental request for CHIP expenditures, which I'll go over, and is offset by decreased SGF expenditures for caseloads. In the middle of page 41 there, you'll see that the governor recommended 3.5 billion, and that includes 727 million state general funds. This is an all funds decrease of 49.4 million and an SGF decrease of 125.5 million from the agency's revised 2021 estimate. The bullets underneath there outline some of the changes that the governor made. There is a deletion of 111 million, and that includes 99.8 million state general fund. And that's to adopt the, or to fully fund the human services caseloads, the fall 2020 estimate. There's a deletion of 3.6 million funds that were reappropriated from fiscal year 20 to fiscal year 21. These were largely operating expenditures or came out of the operating accounts for the different departments. There's an addition of $150,000 to fund the agency's supplemental request for the Kansas Trauma Program. A deletion of $20.9 million, all from the medical programs fee fund, and that removes the increase in the state CHIP state share from the agency's budget. And then finally, there was an addition in the governor's recommendation of $89.9 million. That's all from the federal coronavirus relief fund. And those are funds that were allocated to the agency after they submitted their budget and prior to the governor submitting hers. The governor also recommends 1,598.7 full-time positions. This is the same number that the agency requested in their revised estimate. On the next page, page 42, you'll see a table that describes the agency's supplemental requests. These include funding for a website redesign, for mosquito surveillance and Lyme disease prevention and research. It also includes a supplemental request for the Kansas Trauma Program, oral health preventative. The line for CHIP assistance, you'll see that the agency requested 20.9. The enhanced Fmap that dictates how much the federal government pays for the CHIP program is going down. And so between fiscal year, state fiscal year 20 and state fiscal year 21, the amount that the federal government pays decreased by about 11%, causing the state share to go up. The agency has been funding this through a fee fund, and with this increased amount, it's making it difficult to fund through the fee fund. So the agency has requested that this additional 20.9 that they're anticipating that will make up the state share increase be funded through the SGF. The bottom two lines, you can see the governor's additions for the human services caseloads, and then also some those lapse of reappropriations in KDHE Health. I'm not going to walk through all of the supplemental requests, but each of them are described in more detail underneath the table. I'm going to move forward to page 22. It's page 44. On page 44, you'll see that there's a table outlining the governor's allotments. You can see that several of the programs that the agency has requested supplemental funding for were included in the governor's allotments. Several of these, the funding for the primary health projects, the brain injury registry, the Lyme disease testing, and the local health departments funding were all items that were recommended by the 2020 legislature that were added to the budget in Senate Bill 66 and then were allotted in the governor's allotments in July. You can see on the bottom line there's a significant number for medical assistance. That's largely savings that were created through the increased Fmap. The public health emergency includes a 6.2% boost to what the federal government pays for Medicaid. And so that's created some SGF savings, which were allotted in the governor's allotments in July. I'm happy to stand for any questions for fiscal year 21 before I move on to fiscal year 22.
Are there any questions of the committee? Megan, would you just, I'm sorry, I was a little distracted. Just go over that CHIP fund again, and I'm going to go back to that page. They're not,
Sure.
They decreased or they're getting less.
So the Fmap, the federal match for CHIP is going down, and there's an 11% decrease in what the federal government chips in for CHIP. between fiscal year 20 and 21, and then another decrease between 21 and 22. So the agency is having to fund an increased amount for the CHIP program because the state share is going up.
Okay, so that CHIP is totally related to Fmap as well, correct?
Correct. Yeah,
Okay.
it's just changes in that map.
Okay, thank you. Any other questions for Megan at this time? If not, I'm going to have a little interruption here. I think there might be some confusion that we were going to deliberate on the health stabilization fund. Because we're not meeting in person, we're not going to deliberate on that today. So, and I just saw another email that we may be pro forma tomorrow, but my hope is that we'll be meeting tomorrow in person when we do the KDAT. So if anybody's interested in watching on health stabilization fund, it will not be done today. So thank you, Megan. Go ahead and continue.
Okay. So I'm going to skip forward to page 45. At the top, it'll say fiscal year 2022 budget year. So on page 45, you can see that the agency requested 3.5 billion, and that includes 846 million state general funds for operating expenditures, and that's for fiscal year 22. This is an SGF decrease of 6.3 million, and an all funds decrease. An all funds decrease of 67 million. The all funds decrease is primarily due to a decrease in federal funds that were available in fiscal year 21 that are no longer available in fiscal year 22 for COVID relief. And that's offset by the agency's enhancement requests, again for CHIP, and then another request for local health departments. The agency requests 1,598.7 full-time positions, and this is the same number that they requested in fiscal year 21. In salaries and wages, you'll see that there's a slight all funds increase. This is due to a shift in employee benefits, and then also the agency's enhancement requests. On the next page, contractual services. Well, really for contractual services, commodities, and capital outlays, each of those you'll see that there's an all funds decrease, and just the opposite of last year. That's because federal funds came in 21. They're not available in fiscal year 22, so we saw those all funds amounts go down. In the other assistance category, you'll see that there's an all funds decrease of 23 million and an SGF decrease of 8.4 million. This is a decrease in federal COVID funds, and then a decrease in the amount that was budgeted for the caseloads. At the bottom, you'll see that the governor recommended 4.1 billion, and that includes 841 million SGF for fiscal year 22. This is an all funds increase of 550 million, and a state general fund decrease of 4.5 billion. So under there in the bullets, you can see the changes that the governor made. Again, there is 150,000 that were added to fund half of the agency's supplemental request for the trauma program. There is a deletion of 12.6 million all funds, and that included the addition of 10.8 million SGF. That was to fully fund the fall 2020 Human Services caseloads estimates. On the next page, page 47, you'll see that there is an addition of 596 million all funds, and that includes 19 million SGF to fund Medicaid expansion. A deletion of 29.1 million from the medical programs fee fund, and that is to remove the increased state share of CHIP from the agency's budget. Finally, you'll see that there's a deletion of 1.1 million SGF from the administration program, and that was supplemented with funding through fee funds. The governor recommended 1,598.7 full-time positions, and that's the same number that the agency had requested in their 2021 revised estimate. On page 47, you'll see the enhancements table.
Megan, before we get to enhancements, I want to ask a question.
What's that? I'm sorry.
So on page 46 at the bottom, so the governor's deleting 10.8 million from SGF. So does that mean she's not planning to fund the human services caseload estimates?
So that's the adoption of the so the difference between the agency's budget and then what was estimated in the fall caseloads, which is the most updated. So she did fully adopt those.
Okay. Thank you.
Mhm.
Madam Chair, I have a question.
Go ahead.
It's back to the CHIP. And so, Megan, so the governor, I mean, we deleted 20, a little over 20 million in the 2021 budget, and now 29 million in the 2022 budget for the CHIP. Isn't this going to impact the number of children that the CHIP services can be provided to?
If it goes unfunded, then it would influence the program. Yes. My understanding is that there are discussions being held to find a way to fund it, but that at this point, it's not in the agency's budget. I believe there's an intention to put it in somehow to fund it.
And is that 11% decrease in the federal match, is that going to change?
It is. It should even out. So between 2021 and 22, it's going down pretty significantly. And then I believe at that point, it should start evening out. And the amount should stay higher than it has been.
But you're saying it should stay higher, but it may not stay as high as 11%?
So the federal share went down 11%. So the state share went up 11%. And that was between 20 and 21. And then between 21 and 22, the state share went up again, but I think only by maybe 5 or 6%. I don't have the numbers right in front of me anymore. And then that should, I believe, continue, whereas the state share will maybe continue to go up a small amount, but not as substantially. Does that make sense?
Yes, but I don't quite understand. So is that because the federal law is continuing to reduce the share? Is that
right? The adjustments, I believe, are due to the Affordable Care Act.
All right, thank you.
Mm-hmm.
All right, go ahead and continue, Megan.
Okay. So on page 47, the enhancements table, many of the agency's enhancements were the same as those that were requested as supplementals in 21. Mosquito surveillance, website redesign, Lyme disease prevention. There are some new ones, the disease intervention for primary and congenital syphilis transmission, as well as the harm reduction advisory council. And then another addition in fiscal year 22 was money to for aid to local units for local health departments. And then that was 2.6 million. And that is to supplement the amount that is given to local health departments using the state formula funding.
Megan, is that more than what we were planning to do last year, or the same? Because we had tried.
The legislature last year in Senate Bill 66 had added 900,000 for local health departments
To fix that formula. So we did it less than what the actual proposal is. Okay, thank you.
Right. And there's detail about it on the next page. Or I believe there's detail about it on page 49. But the agency describes that the current formula allocation was established in 1992. It's remained at that same amount, which is 2.2 million since that time. So the they've come to this number by adjusting for population and inflation changes over that time period. Also in the enhancements table, you can see the numbers for the funding the fall human services caseloads, as well as the 19 million SGF and 596 all other funds for Medicaid expansion. I'm going to move.
Megan, before you move on, Madam Chair, on that oral health prevention services, so this is the 150,000 that we put in last year.
I don't believe this was fun. I could be wrong. I know that there was money added in Senate Bill 66 to increase reimbursement for some dental codes. That was separate than this. This is for school-based programs.
Okay, so we didn't do anything in last year, and but this is also not funded this year.
I can't say for sure that it wasn't funded last year. I'm pretty sure about that, but it is not funded for this year. Correct. Well, it is, it wasn't funded for fiscal year 21 because they asked for it as a supplement in 21 as well as 22.
All right, let's continue.
Okay. On page 50, you'll see the reduced resources. The governor requested that specified agencies with SGF monies provide a reduced resources budget submission of 10% for fiscal year 22. So in this table, you can see that the agency submitted 9 reduced resources, and that totaled approximately $19 million, including 9 million SGF. In the governor's recommendation, she did not include adopting any of those reduced resources package, but she did remove $1.1 million from the Department of Administration's budget out of SGF, and that was replaced with funding from fee funds. And that concludes my fiscal year 22, my presentation. I'm happy to stand for any questions.
Any questions for Megan? All right, before we get to the secretary and other individuals from the department, just want to let those that are online that will be testifying to please keep your comments less than 5 minutes. And Megan, I don't believe we have their testimony. Is that correct?
The agency's testimony?
No. Well, I don't think we have anything, but unless you sent it and I missed it.
I think that would have come from Nancy.
Okay. So, and I know they're all trying to work from home. So, the agency, you certainly have more than 5 minutes if you need it. And then, for each one of you. And then, but I just want to let the others, in case you need to change up your, testimony, please don't read us 3 pages. Get to your points because we do not have that information in front of us. We'll have it as soon as we meet tomorrow and be able to look at that. So I just want to let everybody prepare in case you have a really long testimony you'd like to read. So at this time, we will go to Secretary Norman for his comments. Welcome, Mr. Secretary.
Good morning, Senator McGann. This is Ashley Goss.
The secretary have to get off, or are you next?
No, he had to jump off for a joint caucus meeting.
Okay, that's
Texted
fine.
you.
If he comes back on later, just let me know, and if he needs to make any comments. So, all right, welcome.
Certainly. Thank you, and good morning to the committee. So I'm going to provide our agency overview briefly, and then I'll provide you some information about public health, and then we'll turn it over most likely to Mark Heim, the CFO.
Just a comment here. Ashley, you're kind of ringing, but and I'm glad you've got an overview on slides. But so I don't know if that's on your end or if I don't know if Robin can do anything, but Just in case there's other mics or something on, just FYI. It's not really bad. I just want to let you know if there's something else you can do there. So.
Yeah, probably not. I'm in the Emergency Operations Center, and so I don't know if that has anything to do with it
Okay.
or not, so I apologize.
That's all right. You got
All
started.
right.
Thank you.
Yes. All right. So next slide, please. And next slide. All right. This just shows you what our agency vision and mission are. I don't need to read those to you. Next slide. So in the Kansas Department of Health and Environment, we are comprised of 3 divisions. You will hear today from the Division of Public Health and the Division of Healthcare Finance. The Division of Environment is heard in another committee. Also, in support of those 3 divisions, we have the Administration Office, which is comprised of the 6 categories you see there listed on the slide. Next slide. So these are our agency priorities. What I would call out here is we're a unique state and a unique agency when looking at the other 49 states, where they still remain the only state that has all 3 divisions under one roof, under one agency. The most important thing to us, obviously, besides our everyday work, is recruiting and maintaining manpower. Without them, we could not be successful. Next slide. All right, so I can briefly talk on some of these. I know you don't have the notes that I'm going to provide off of these. So this slide we showed last year. These are America's health rankings for the state. And this year, because of COVID, they did not do all of the individual data, which normally they would in any given year. So let me briefly tell you about these 5 areas quickly. So just a background for these rankings, America's Health Rankings published an annual report for the last 31 years. And normally in this report, they highlight 74 measures of population health, covering social and economic factors, physical environment, clinical care, behaviors, and health outcome data, drawing 20 publicly available data sources. Regarding, and as you can see, Kansas is average in all of these, with the exception of clinical care, we happen to be below average. So always something for us to strive to increase. In a behaviors category, they look at the following factors: sleep health, nutrition, physical activity, sexual health, and tobacco use. As you can see, we rank 26. In physical environment, they include air and water quality, climate change, and housing transit. Social and economic factors, in community and family safety, economic resources, education, social support and engagement. And in the clinical care category, it includes access to care, preventative clinical services, and quality of care. And just based on the 3 categories, I'm sure that you can imagine why we're below average. These are all things that we hear on a daily basis almost. The outcomes category includes behavioral health, mortality, and physical health. Some identified for our state: low income inequality, low prevalence of severe housing problems, and low prevalence of low birth rate. Challenges that were identified for our state: high prevalence of household food insecurity, high prevalence of low prevalence of exercise, and of course a high prevalence of obesity. Next slide. So the Division of Public Health, which happens to be the division that I oversee, here are some of the highlights or accomplishments that our division has accomplished over this year. And I'm going to, you can read the bullets there, and I'm going to dive into the newborn screening just a little bit. On January 2nd, our newborn screening program added 2 of the lysosomal storage disorders to the blood spot screening panel. If you guys remember, we spoke about this last year and that we were adding these to the state test. These 2 were Pompe disease and mucopolysaccharidosis, or MPS1, were added with 1 small blood sample. 32 life-altering and life-threatening genetic and metabolic disorders will be detected. These are completely undetectable at birth without the screening. Over 36,000 babies, Kansas babies, receive the newborn screening each year after birth. The LSDs, or the lysosomal storage disorders, are a group of diseases that prevent some cells from breaking down fats and sugars, resulting in a buildup inside the cells, causing them to swell. Left untreated, this buildup causes tissue damage and can result in a variety of symptoms. These symptoms are not visible at birth, but the newborn screening for these conditions leads to early diagnosis and treatment, identifying them before the condition can cause permanent disability and supporting better outcomes overall. Pompe has an incident rate of 1 in 40,000, and MPS 1 has an incidence rate of 1 in 100,000. These two conditions were added to the federal recommended uniform screening panel for newborn screening in 2016. Kansas just added them in January. Kansas is now screening for 34 of the 35 conditions that are recommended in the screening program. The last condition for which Kansas does not currently screen is called XALD, or X-linked adrenoleukodystrophy, which I will continue to refer to as XALD. This is a genetic disease that affects the nervous system and adrenal glands. People with this disease often have progressive loss of fatty covering, otherwise known as myelin, that surrounds the nerves in the brain and spinal cord. According to HRSA XALD evidence report, the overall U.S. incidence of having at least one mutation associated with XALD, regardless of sex, is estimated to be about 6 per 100,000 births, or 1 per 17,000. This session, we have introduced House Bill 2250, which would increase a cap placed on the fee fund that supports our newborn screening program. This bill would make permanent the changes that were included in the budget last year as a proviso. Permanently increasing the cap through statute from 2.5 million to 5 million is vital to ensuring resources are available to conduct a quality, effective, and efficient newborn screening program. The implementation of an advanced universal newborn screening program provides newborns with genetic or metabolic conditions, hearing loss, and critical heart defects the best chance at healthy development. A couple of other highlights in our division. The Bureau of Family Health partnered with Child Care Aware of Kansas to administer a coronavirus relief fund project to assist licensed child care providers with mitigating the spread of COVID-19 through Care Health Consultant Network. Between September and December of 2020, approximately 2.5 million in funding was awarded to 440 home and center-based facilities across the state, reaching nearly 12,000 children in care. This covered infant through school age kids. The program continues with alternate funding sources. We did establish and still maintain a COVID-19 phone bank. We've handled 23,289 emails for the inbox, which was created in March of 2020. And our phone bank has handled 28,442 phone calls since we established the hotline. In addition, an intentional drug overdose reporting system. We support KDHE collects and abstracts data from the death certificates, autopsy reports, toxicology findings, and law enforcement reports through SUDORs, programmed to present a holistic overview of the drug overdose problem in Kansas. More than 200 data points have been collected through SUDORs, and their work has been instrumental in driving prevention efforts across the state to combat the opioid crisis. Next slide, please. These are the 6 divisions that make up our Division of Public Health. These have not changed since you saw them last time. Next slide. And as Megan talked about briefly, these are the enhancements and reduced resources listed here. The enhancements, as you heard Megan talk about, is to our trauma fund. We are short 300,000, and the governor has approved 150,000 to be added both this year and next year. And then you can see our reduced resources. If you have questions on that part, Dan Timish can certainly answer those. And Senator McGinn, that's all I have on my division. So I'll turn it over to Mark for Division of Healthcare Finance.
All right, great. Hey, Ashley, can you send, well, just send it to me, and then that way I can send it whoever requests it. But can you send your PowerPoint to my email? And then I can get
Certainly.
it to Senator Kirsch and Senator Petty. All right, thank you.
Mm-hmm.
All right, we will continue.
Thank you, Madam Chair. This is Mark Heim. I'm the Finance Director for Healthcare Finance, and members of the committee. Thank you for the opportunity to present to you today. I have just a few slides that I'll cover for Healthcare Finance, and I know our Medicaid Director, Sarah Fertig, is on call as well. And so I'll take care of the slides. And then if you have questions for us, between Sarah and I, will answer those for you. My slides begin on 11, and we'll go ahead and forward to the next slide, please. And this slide 12, just highlights a few accomplishments that we'd like to point out for healthcare finance. The first one deals with COVID, the COVID environment we're in, and some adjustments we were able to implement. And I would say one I'd point out would be telehealth. And so working with KDHE and KDADS, we were able to make some pretty quick changes to the Medicaid program so that the beneficiaries could continue receiving the services that they rely on. And at the same time, you know, while implementing changes, we were, of course, having to stay within what the federal rules require of us. So, like I said, telehealth was one, you know, that was pretty hot topic, one you heard a lot about, and that's a good example of that bullet point. The second bullet point, some of you may over time have heard about this one. The newest MCO is Aetna. They were on a corrective action plan for a while, and we were working through some challenges with them, but I'm happy to report that as of last summer, actually in June, about mid-June, they were released from that corrective action plan, and things are running much better with Aetna. We had a successful transition as well from Maximus, which had been our vendor. The new clearinghouse contractor is Conduit. And again, another thing that kind of was taking place in the COVID environment. So we lost some time there due to COVID challenges. But as of just last month, early January, we were able to implement the new vendor Conduit. Some other legislation from that came out of last year, we were able to increase the personal income limit from 747 to 1177, and this was reduced some client obligation for quite a few members. The regulation for that, it increased the income limit from 150% of their SSI to 300%, and that it set it at 150%, I should say. And that became effective last month as well in early January. And happy to say that the application backlog issues have been eliminated. Next slide, please. What I would point out here, kind of the different things, you know, that we're working with analytically, operational, and public health. You just heard from Ashley on public health issues. Something I would point out on this one is that we're undergoing a pretty massive modernization project with our MMIS, or our Medicaid Management Information System. And this one is scheduled to go live in January of 22. So we're about a year out on that. Next slide, please. Looking at the healthcare finance budget, the largest driver, of course, is the caseload, which you heard Megan mention several times and cover some of those aspects. But what I would point out here is a little bit more kind of about the process itself. And so as we go through the caseload, we're looking at our current year and out year needs in terms of funding. There is a estimating group that involves Megan gets to be, she's part of that, legislative research, division of budget, KDADS, DCF, KDHE, and we meet twice a year. And so you hear about a spring caseload, which is actually coming up in April, and the fall caseload. So for the spring caseload, we shoot for April. Fall caseload, our target is October. And we come together as a group, and you know, everybody provides their input, and we come to a consensus on the numbers. What we're looking at, you know, it's kind of what are we seeing, and you know, what are the trends? So what are we seeing in terms of, population, the enrollment, and then putting the funding to that. Other things that can play into in addition to the population, sometimes the population not only increases, but maybe there's a change in population groups. So one may be up, one may be down. We're looking at program updates, legislative mandates that took place, internal policies, something that was mentioned that comes to mind. There was some funding for some dental codes last year. I believe it was about 3 million all funds, but things like that do play into the caseload. So we'd be looking at something like that. And then, of course, another thing you've heard about, Fmap, so the Fed's share of what they will pay. And so we're looking at the Fmap in terms of what is the percentage, and then where will it be, in the next year. Next slide, please. So this kind of continuing with caseload in a sense, because this is looking at the expenditures versus the populations.
It's muted now, the green.
So
Unmute is a red for mine too.
We need to make sure everybody's please muted.
So this bar chart shows the top line is the expenditures and the bottom line is population. So this kind of show you, there's a lot of money in caseload, obviously, and a lot of members. So this is showing you the population within the groups, and then where are the expenditures. And I'll just, on this one, we're pointing out that the children and parents, obviously, is a large group, 74% of the population, but at this time accounting for about 33% of the expenditures. So that's an example of where the population is versus where the expenditures are. Next slide, please. So this one are, again, talking about the population trends. So this shows you 6 years of actuals. So you're not seeing fiscal year 21 on here yet. You would see that next year. Obviously, we're in fiscal year 21 right now. And again, we have the same, we're pointing out the same comment, the 74% in the family and children groups. But if you were to look at our numbers today, we are at about 460,000 right now in terms of population. And that's what you kind of think of that as that's due to the MOE for the PHE. So the public health emergency that is in effect, and the MOE is the maintenance of effort requirements that the federal government requires of us if we want to continue in order to keep continuing to receive that 6.2 additional Fmap. There are things we have to do, requirements we have to do to receive the additional funding. And one of those is that everyone on the roll continues to stay on the roll through the end of the public health emergency. Next slide, please. So again, you've heard mentioned several times of the Fmap, and this is basically the Fmap chart for last 5 years. If you look, I'll kind of draw you, this is a busy slide, there's a lot here, but if you look kind of towards the middle, a little bit lower half, and we'll look at federal fiscal year 21, that's the last row there, kind of in the middle of the page. But just as an example, we would be at about 60% would be the federal participation right now, but due to the PHE and the increased Fmap, we're at 65.88. So there is where you see the 6.2% come into play. And then the last two columns, the enhanced Fmap, we do get a couple enhanced Fmap categories for breast and cervical cancer, and then there's a CHIP and MCHIP. But the 6.2% does, since those are already enhanced, the 6.2%, it does have some effect on those, but it's not full 6.2%. Next slide. So as Ashley talked about in her slides, we also, some enhancements and some supplementals. So the first bullet point, this is the CHIP that was talked about a little bit. We did have a supplemental request of just about $21 million for CHIP increase. And as Megan mentioned, the federal share of CHIP is going down. So the state's share is going up. And in 22, it's the same situation. The Fed share goes down again. And so the state share will go up. So those, it'd be a supplemental in the current fiscal year and an enhancement in fiscal year 22. And I should mention there under fiscal year 22, that's actually, we're missing a dollar sign there. I see that's actually $19 million for Medicaid expansion that the governor added in her budget. And I think that's my final slide. But again, would be happy to stand for questions at the appropriate time. And thank you again for the time.
Marcus is, Madam Chairman, I have a question.
Go ahead.
Mark, this is Senator Petty, and on the CHIP, is that going to continue is the federal match going to continue to decrease? Is this an ongoing, or is there a stop point?
So I think, thank you for the question. I think as Megan had spoken to, it's decreasing in the current year, it decreases next year, and it will level out. But I can certainly follow up with those numbers. Yeah, it's pretty steep decline this year and next. And so we've had some of these, this is something we've been talking about in the last couple, through the last couple caseload processes. I think our thinking, or kind of the consensus that's come out of the group, is that we're hopeful that the CHIP would be funded with state general fund. The fee fund has picked up some of this in recent years, but we wouldn't be able to continue over the long haul.
Okay, other questions for Mark? All right, I don't see any. Thank you, Mark.
Thank you.
Ashley, are we going to go to Sarah next?
Well, actually, I think we're going to go to Dan next. Sarah will answer questions if we follow the format like we did last time.
Okay. Welcome,
Madam
Dan.
Chair, members of the committee, Dan Timish. I'm the Chief Fiscal Officer for KDHE. And so on slide 20, this is a visual pie chart showing showing our funding for fiscal 21. So you can see that KDHE Health is about 2/3 federally funded. This is $2.3 billion for the current fiscal year. Second largest source of funding is SGF, which represents 21% of our funding budget. And then third largest would be fee funds. These are primarily drug rebates and Medicaid space fee funds that runs just shy of $400 million, or 11.6% of our budget. Probably the main call outs here on this slide is that, as Megan pointed out, our federal funds for this current fiscal year do include all of our CRF funds that we receive through the Sparks Committee and the State Finance Council, as well as any awards that the agency received directly from federal partners. So the total budget is $3.4 billion on the next slide. Then on slide 21, same fiscal year, just looking here at our expenditures. So the largest portion of our budget is aid and assistance. So this would be Medicaid and CHIP, as well as our public health aid to local grants. And then secondly would be contractual services. A lot of this is in the Medicaid space, where ks.gov, our fiscal agent, supporting that program. And then the third largest expense would be salary and wages at $73 million, or 2% of our budget. Flipping to slide 22, kind of the same thing here now for next fiscal year. So the largest again is federal, 66%. Of course, in the federal funds for 22, fiscal 22, we have 577 million for Medicaid expansion, which the governor put in her budget, and then we do not have the anniversarying of the CRF funding. And the largest, second largest, again, SGF, 837 million, 21% of our budget, and the third largest, again, fee funds, about 500 million or 12.5% of our budget. And then on slide 23, looking at expenditures, kind of the same picture. Agent assistance is 90% of our budget. And then we have contractual services at 7.1% and then everything else. On slide 24, this is a slide we always include just related to public health. And this is taking the total SGF allocation for each year that public health receives and showing you how much of that is for matching grants versus non-match. So you'll see for fiscal 21, the budget for matching grants was 8.3. And that draws down roughly $30.1 million in federal funds for fiscal 21, which is 3.5 times the SGF investment. And then you'll see in the following year for FY22 or 7.7 million in matching grants, and that draws down about 29 million in federal funds, again 3.8x. And then the next row there, the non-match, that's primarily, you'll see the footnote number 1, that's primarily our community-based primary care clinics, or is the biggest portion of that 17 million. And then also included is our aid to local for local health departments, tiny K, maintenance of effort, and then everything else. Moving to the next slide then, wanted to just give you a quick overview here of give you a sense of the amount of COVID-19 funds that the agency has received thus far. So on slide 26, this is really just a listing on the left side of slide 26. You will see each of the projects that we requested and were awarded through the State Finance Council and the Sparks Committee. These total 128 million. The first group of these are round 2, down through technology for families, and then starting with cars for vaccine distribution are all of our round 3 awards. And then over on the right side of the page, our public health emergency grants that were awarded directly to KDHE in 2020 calendar year totaled 110.5 million. And thus far in calendar year 21, we've received $203.8 million in direct awards from the federal government. And then we also wanted to include, Mark has talked to you about the 6.2%, as did Megan. And so you'll see the amount that we reported to the Recovery Office, both for fiscal 20 and fiscal 21, related to the value of the 6.2, and the amounts are there for both Medicaid and for CHIP. Just a quick call out, down at the bottom right, you'll see a footnote. This does include Division of Environment, so we're reporting on public health here, but I did include the, I think there were 4 of these round 2 and 3 awards that related to the lab, and the lab does not roll up into public health. It's part of our environment. So this is a total listing here for the agency of all of the total funds that we've received thus far. And Madam Chair, Committee, with that, I'll stand for any questions, as will the rest of the KDHE team.
All right, any questions for Dan? I don't see any right now, Dan. So does that conclude, did the secretary, is he able to get back on yet?
No, he's still in another committee, so we're gonna begin.
Okay. Ashley, is there anyone else that from your agency that wishes to speak?
I don't believe so. I think that's all of us.
I have a quick question. The Marathon Health Clinic, is that under you guys? Because the administration portion, went, or part of it went to the administration. But Marathon
Right, that's
Health,
a state employee health plan is now operated under Department of Administration.
okay, so but your role is to pay whatever, you do the negotiations with Marathon, or how's that work?
I cannot speak to that. Dan or Mark may know those details. I do not.
I just want to be clear. So I know the Department of Administration took over some of the functions. So Dan.
Yeah, this is Dan Timish. Effective with this fiscal year, or July 1 of 2020, the state employee health plan, as well as the state employee workers comp plan, that group moved to Department of Administration, and so it is no longer part of KDHE, and I believe they have the oversight for the Marathon Health Clinic.
Okay, so to be clear, they handle all the contracts with them as well.
That's correct. We do not, so yes, I believe that would be a question for them.
Okay, thank you. And then trying to find what page, here we go. So your FTE positions went up about 98 folks in 2021, I assume, because of all the COVID activity primarily. Would that be correct?
Yeah, that's correct. I think Megan called that out with some detail, but it was our contact tracing, case management, epidemiology. It was driven by the public health emergency.
So I guess my question is, I know you extended out through 2022. If COVID would ever slow down, you see, I'll go back and look at those details, but you see that you need all 98 even after we get past a COVID crisis? I'm always trying to figure out, are those FTEs tied with a certain situation, or, you know, and then they go away with that situation, or are we just gonna, we're just gonna grow by 98 folks and keep it there?
Senator McGinn, this is Ashley. So we typically, when we hire people in an ordinary setting, we try not to hire them for specific situations. We want to hire them on long-term if we can. Otherwise, we look to see how we can manage with the current staff that we already have. But given COVID, it has created lots of opportunities and identified gaps in positions that we need. So I don't know that we would necessarily keep all 98 on if COVID would ever slow down. But we could potentially keep some of those on, because some of those are additional epidemiology staff and things like that. And quite frankly, over the last several years, not just 5 or 6, but several years, as you're well aware, public health has remained unchanged as far as funding goes, not only at the state level, but at the local level as well. And in prior administrations, whenever we had a vacancy at our agency, we were told to not fill it. And so we've been operating very slim as far as staff goes, and multiple staff have been wearing multiple hats for several years. And then you come up with a pandemic like this, and it really takes a toll, and you really see quickly where you're lacking and where your gaps are. So I would certainly say probably not all of them would go away, but probably some of them will. I just don't know the exact number yet. We're not far enough out yet to be able to make that prediction.
No, I know, I certainly can see that the pandemic would have drawn attention to the fact that we in government, we always try to understaff, but those could also get adjusted over time through attrition and things like that. That'd be correct. Okay. Other questions from the committee? All right. Well, and is anyone else from the department actually need to have any comments? Okay.
I don't think so at this time.
Okay. All right. Let me find that a little agenda here. And thank you all very much. So next we have Jeanette Pryor from the Kansas Catholic Conference. And Jeanette, this is an old agenda. It says you're going to be in person, so I certainly hope you're on WebEx.
Yes, they wouldn't let me walk over.
Good for them.
But I'll just be really brief. So I'm here to testify in favor of a grant that's been, it's the Stan Clark Pregnancy Maintenance Initiative. And this was a really modest budget line item that was first funded in 1999. It was named later for a pro-life Kansas senator who passed away tragically during the 2006 legislative session. And the funds in this grant are used for integrated care coordination for young mothers during crisis pregnancies and for the first 6 months after their babies are born. They're specifically set aside to provide material and emotional support for young moms, again, who are in crisis pregnancy. This is a $340,000 grant, but it has to be matched dollar for dollar by the organizations that apply to be grantees. And the funds are used for pre and postnatal care. They're used for child development and parenting classes, community resource navigation, also, which is really important for job training and professional planning. Sometimes it's used also for substance abuse, assessment and counseling, and then for licensed professional counseling. And also with really young moms, it's used to help guide them through whether or not placing their baby for adoption would be the best choice for baby and mom. And last year in the KDHE report that we were sent, they said that there were 560 babies and moms who participated in the program, and 205 babies were born. Usually they have a few more moms that participate, but because of COVID-19, it was just hard to get the word out that this service was available. And there were 9 grantees, including 3 public health departments, and then a few Catholic charities, and then some other organizations in Wichita, so caring pregnancy centers. But anyway, we were just wanted to thank you all very much for your continued support and funding this each year, and ask that you continue to do so this year. And I'll be happy to answer any questions that I can about this program. And thank you again for having us here today in these odd circumstances.
Thank you, Jeanette. Any questions for Jeanette? All right, I don't hear any. Thank you for being with us on this cold day.
Oh, you're very welcome.
This was Senator Petty. So is that a continue? That's the 240,000 has to be matched. Is that correct?
It was 340,000, Senator, and yes, any organization that wants to participate, they have to match that dollar for dollar.
Thank you.
All right. Next on my list is Tanya Dorf-Bruner, Oral Health, Kansas. Tanya.
Hi.
I may have botched your name, but
I think you got it right. Thank you, Chair. Thank you, Madam Chair. I will be brief as well. I know time is short, and I really just want to do a couple of updates and thank the committee this afternoon. So again, my name is Tanya Dorf-Bruner. I'm the Executive Director of Oral Health Kansas. When you have copies of your testimony, it's going to look something like this. There you go. The first thing I want to just update you on is the Medicaid dental rate increase, and this is something that Mark referred to in his testimony a little bit ago in an agency overview. So as the committee hopefully remembers, last year you were helped champion a rate increase for the Medicaid dental services. This was the second rate increase in 2 years. It was a really big deal, and we hadn't seen one in about 20 years. And so it was really important to be able to get that increase in place. We're really, really hopeful that it's going to make a significant impact on the Medicaid dental provider network. I had hoped to be able to come to you and was planning to come to you this year and say, here's what we know so far about how much progress has been made in terms of that dental provider network. But as with pretty much everything else, COVID has kind of interrupted plans and has made it more challenging to get more dental providers on board than we had ever imagined. But again, it's COVID, and we think that's all going to turn around here after, hopefully when we can get to a slightly more normal world. But I can say the agency is telling us about 8 new pediatric dentists have joined the Medicaid program since the first increase went into effect in 2019. So that's a really big deal, mostly because Medicaid covers comprehensive dental benefits for kids rather than adults. And so if we've got 8 new pediatric dentists wanting to become Medicaid providers, that's pretty meaningful. So I'm hopeful that that's a harbinger of more good things to come. And just really want to, again, thank you for being a champion of that increase. Looking forward to that, to being able to report even better news in the future. The other thing I just want to update you on is, we've been coming to you for a number of years, and hopefully not too many more years we'll have to do this, but to talk about funding for an adult dental benefit in CanCare. As I mentioned a few minutes ago, there's not a comprehensive benefit for adults. That's something that's a perennial issue for us, and we're going to keep on talking about it. But I want to just update you on a couple of things. First of all, just last week, a new bill was introduced. Senate Bill 227 was introduced, and that would establish a comprehensive adult dental benefit. We'll kind of see where that goes, if we can get to it this year, or if that's something that gets taken up next year. But the thing I really want to bring your attention to is we are working with the American Dental Association's Health Policy Institute. That's their research division. I kind of think of it like the Kansas Health Institute. They're kind of an independent arm that does a lot of economic and health research. They're working with us on putting together a study that will show not only the cost of an adult dental benefit in Kansas, but also the offsetting savings, especially related to pregnant women who can carry full-term babies, related to people who are trying to manage diabetes, related to even just emergency room visits. People at this point still go to emergency rooms when they have dental pain, and there are no dental services available there. So this study is going to take a look at some of those offsetting things that can be saved if we can get a comprehensive benefit in place and then actually bring services to people. So we're hopeful that study will be out in March. As with everything, it takes a little bit longer than we'd like, but hopefully it'll be out in March, and we really look forward to sharing that with you as soon as it's available. I think that's about it. The only other last thing just to share real quickly is you may have seen we put out a report card this month on oral health in Kansas, giving the state of Kansas a C. That's wasn't a passing grade in my family, and it's not. There's a lot of grades that don't really look very good, and so that's something we can talk about more in the future as well. But hopefully you've seen that in some emails we've been sending to legislators. But happy to talk about that at some point. But mostly want to thank you for that rate increase. Tell you there's some data coming, and look forward to more conversation. So thank you.
All right, thank you. Any questions? All right. Thank you very much. Appreciate your testimony. And we do have a link to all this testimony, and we'll get it printed.
Okay. Good.
I'm trying to find my agenda again. Hang on. So figure out who's next. Not getting there. There we go. All right. Thank you, Tanya. Dennis Kreisel, Association of Local Health Departments. Are you online?
I am online.
All right. Welcome to the committee.
All right. Thank you very much. Thank you for having me. So my name's Dennis Kreisel. I'm the Executive Director for the Kansas Association of Local Health Departments. And we've come before you to request the committee to consider adding $2.6 million, all via the State General Fund, in fiscal year 2022 to aid the local health departments for statutory formula distribution as listed under KDHE's Division of Public Health. So the governor's budget allocates $2.2 million for such aid in the fiscal year. And so this enhancement would raise that to $4.8 million. In public health, we commonly refer to this as the state formula. And so this is the funding that was discussed by Megan earlier that hasn't been increased since 1992. And as she also noted, you all did approve $900,000 for our first time since 1992 increase in the fiscal year 2021 budget, but we lost that in allotment. So we're back at square one, coming before you again. So my written comments have the sources and the math, but essentially what this does is it takes the 1992 per capita value, adjusts it for inflation, multiplies it by the current Kansas population. So that's what derives the 2.6 million increase. For those that aren't familiar, the state formula is it's a discretionary, it's like a block grant. So it's really discretionary in its use. So health departments use that for a variety of functions. Some of those are to do their statutory responsibilities. So we're talking disease control and investigation, school inspections, immunizations, nuisance law work, environmental health functions, but also local health departments function as the chief health strategist for their counties. So they provide a lot of services that have been identified separate from statute that our community needs. These would be things like senior services, home visitation, car seat safety, and things along those lines. And then I'd say the third thing to kind of stress, though I don't think I need to, because everyone on this committee is aware that the pandemic with COVID-19 has really showed that our public health system is strained at this point and is in need of modernization. So there are a number of health departments that are interested in a permanent increase in the state formula so that they can move forward with actually progressing into the 21st century with their departments. So again, it's been almost 30 years since we've seen an increase. We almost had one last year, and I'm hoping that we can move forward with this at some stage. But that's all I wanted to say. I'll stand for any questions.
Dennis, let's see here. Can you tell us what are some of the largest strains on our local health departments? Was it staff? Was it, ability to pay good staff over the years, or what?
Right. A lot of it depends on the size of the department. So, and some of the more rural departments, yes, staffing and being able to attract and retain quality staff is a major problem. I had spoken with a now retired health department director who was, I believe she ended her tenure in January, but her county was looking to find a replacement and they finally did, but they were talking about a pay for a director who was also a nurse in the like $20 to $22 an hour range. And it's not competitive. It's not competitive with the hospital that was in the area. So some of it is just being able to catch up on those salary levels so they can actually attract and retain good staff. On larger departments where they have more diverse funding streams, it could be more on the logistic level or system level. So we're talking about software systems, necessary upgrades. I think there are probably at least, I'd have to check our latest state formula survey, but I think around at least half of the health departments don't have true electronic health record systems, which again, when we're doing the vaccinations with the pandemic, those systems are what are supposed to automatically talk to the Kansas WebIZ, which you've been hearing about is having issues on the vaccine tracking. So they don't have to direct entry that or type it in twice if they're using a non-EHR system and an EHR system. So there's some of those sort of things as well. Obviously, there are a lot of one-time funds that are coming to address COVID specifically, but those items are one time and have to be tied directly to the pandemic. And there's so much more that we're trying to do: chronic conditions, social determinants of health. So yeah, some of it's staff, some of it's more upgrades, some of it's longer term project work. It depends on which health department you are, the size of your community, and the other resources you have. Did I lose everyone?
No, it says that she has low bandwidth, Dennis.
Oh, it told me I had low bandwidth too. So
Yeah, Dennis, this is Senator Petty, and Senator McGinn does have low bandwidth. So now we appreciate your presentation. We're going to go on to the next person. And the next presenter is Denise Seisman. And so for everybody's information, Senator McGinn's going to go out and come back in. Okay. So Denise, if you're on here, we're ready to continue. Looks like nothing's happening now.
Can you hear me now?
Yes, Denise, thank you.
Great, thank you. So Senator Petty and members of the subcommittee, my name is Denise Seisman, and I'm the Chief Executive Officer of the Community Care Network of Kansas. And thank you for the opportunity to present oral testimony as you consider the KDHE budget for state fiscal years 22 and 23. We are requesting an additional $5 million in funding to support the network of state-funded community-based clinics as equitable access to health care continues to be a challenge. We are very grateful that you and your colleagues in the Kansas Legislature have demonstrated a long-standing commitment to this network. For more than 30 years, you dedicated state funding to help the network serve Kansans who are or underinsured or who otherwise have challenges with their ability to pay for care. Your investment is a sound one. Clinics can provide care to 3 patients for an entire year for the same cost as 1 visit to the emergency department. Each year, we come to you and we share with you that the network of state-funded clinics have served more Kansans and provided increased services. 2020, as you heard from everybody, was a bit of an exception as COVID resulted in a slight downturn in patients and visits. And even still, they served almost 300,000 Kansans through 950,000 visits. The network of state-funded clinics serve the most vulnerable Kansans in communities facing significant challenges to accessing care. Almost all patients had income levels less than 200% of the federal poverty level. 1 out of 3 did not have insurance. And we know there were many as well who were underinsured, having high deductible health plans, or perhaps even having health insurance but not dental insurance. This is where the state funding comes in. Funding keeps the state network strong, allowing the clinics to serve the most vulnerable Kansans close to home. This is true today, and it has been true for decades. Now, though, enter COVID. It has a little bit of a spin on impacting on what the clinics are doing. The effect of COVID-19 on the state economy has been significant, but the effect on individuals has been even greater. We know that there are more people unemployed, more people without health insurance coverage, and more people making less money. The need for state-supported health care is greater now than it has ever been, and these individuals are showing up at community care clinics to receive care. The public health emergency impacted how often people sought care, resulting in significant pent-up demand, and this is especially true for dental care provided by the state-funded clinics. We anticipate that utilization of services that have been delayed will be compressed in the years 2021, our current year, and 2022. And perhaps most troublesome is that mental health and substance use disorder needs have worsened during the pandemic, and community care clinics are needed to provide more behavioral health services now more than ever before. The number of patients and visits have been increasing steadily for years, while the state's investment has remained relatively stable at $36 per person served. Even with $10.6 million in state funds, which is significant, the clinic still needed to provide $48 million in uncompensated care. So last year, you realized the status quo wasn't going to continue to work, and the Kansas Legislature added $2 million to the state funding for community care clinics in state fiscal year 21. This was cut during the governor's allotment process to shore up the state budget at the beginning of the public health emergency, and now more than ever, the state-funded clinics need this funding. Providing state-funded clinics an additional $5 million will help protect the state's long-term investment in the network of clinics that provide care for the mind, body, and mouth. And it will protect the network that has been an important, trusted part of the state's response to COVID-19. In summary, community care clinics prove their worth to the state on a regular basis, but it is a struggle for the clinics to keep up with the overall steadily increasing demand, and adding $5 million to the community-based primary care clinic program would help to reduce the growing amount of uncompensated care. As an FYI, I did include in my testimony the amount of federal funding that has been received for COVID to the federally qualified health centers, and I'm happy to answer questions about that or stand for questions at the appropriate time regarding my testimony. Thank you.
Senator Petty.
Yeah, I have you. You can speak. I have the mute off if you want to talk.
Yeah, I need to. So you and Senator, you and Senator Carson need to finish the meeting. It's a lot worse than I thought. We just lost power.
Oh.
So anyway, I sent it to the rest of the conferees, and just you and Senator Carson need to just ask to see if anyone else wants to speak and finish it. But I got bigger fish to fry right now.
Okay. Thank you, Senator McCann. And So I will let you
Will
know.
you communicate that to Senator Kirschen? And
I will.
I hear you. I just heard that.
He just heard the whole thing, so you've sent us, the list?
all right.
Right.
You get the list. If you can't find, just ask if there's anyone else that wants to speak.
All
And
right.
I think Tara from the Kansas Hospital Association emailed late, so.
Okay. Thank you.
All right.
All right. Bye. Okay, Denise, thanks for your testimony. And you heard what I had it on speaker, so I think you heard about Senator McGinn. So
Yes.
she's now lost all power, not just her internet connection. I did want to ask you a question. So the $5 million increase that the communities for care clinics are asking for, that there was the allotment that took out the $2 million from last year. Is that correct?
Yes, that's correct. So last year, you all provided us with $12.6 million in state funds, and then $2 million of that was eliminated.
Okay, so now we would be talking about, it would then become, if this amount was approved, it would be 15.6 million. Is that right?
That's correct. Yes.
Okay. Senator Kirschen, do you have any questions?
No, none whatsoever now.
All right, thank you. And thanks, Denise, for your testimony.
Thank you.
I have not looked at the list, or I don't have the list right here. Is there anybody else here to testify?
Hi, Senator Petty. This is Tara Mays with the Kansas Hospital Association. I would like to testify if it's possible. Sorry about that. I think my testimony got in just a little bit late, so I apologize. But if you all have just a couple of minutes, I'd be happy to keep it brief.
Certainly, and Senator McGinn mentioned that she thought you were here to testify. So go right ahead, Tara.
Well, thank you so much. I really appreciate you all allowing me to speak, especially under these interesting and unique circumstances. I'd like to speak to you on behalf of our 102 hospitals in the state of Kansas. I am Tara Mays with the Hospital Association. I want to discuss just briefly a topic that I know is very familiar with you all, and that is the provider assessment. As you all might remember, as Kansas went into managed care, it had gotten just a bit out of whack and was no longer self-sustaining anymore. So in 2018, the legislature directed us, along with a group of stakeholders, to establish a self-sustaining alternative. And as a reminder, this assessment is actually on hospitals, and the funds are collected by the state, and they are used to match the federal dollars, and then they are redistributed to the hospitals and physicians in the form of enhanced Medicaid payments. We at the KHA have continued to work very well with KDHE, CMS, our national consultants, and our federal delegation in the state of Kansas to get those changes that were requested in 2018 developed and implemented so that they can be made. But we don't yet have CMS approval to implement those. So until we do, we would just request mirror language from what you all included in a budget proviso last year that just indicates that in 2021 and in 2022, those provider rates would not be reduced based on the provider assessment. So they'll continue to be paid at the same level over the 2 years until CMS does approve that, whether that's on January 1st or July 1st, just immediately following the approval by CMS. We have worked with legislative research on that, and I believe the chair and in my written testimony, if you don't have it, we'll make sure you get a copy of it. The HCAIP passed by the House, but not by the Senate last year. There was a bill for that, and you all did put it in a one-year proviso. And so we just would request that mirror language, and I would be happy to stand for questions.
Are there any questions for Tara? Senator Kirschen, do you have any questions?
No, that's a good report. I don't have any questions.
So Tara, the ask is that the proviso that was 1 year for last year be part of the legislation again this year. Is that correct?
Yeah, so it's essentially mirror language to what was provided last year. And like I said, we have worked with legislative research on that. And then just incorporating it in 2021 and 2022 allows us to then have that in place as soon as CMS does get the approval.
All right. Thanks so much, Tara. Thanks for your testimony. And we will have it in writing. We just don't have it before us right at this moment. Thanks again. Is there anybody else here on that needs to testify or wants to testify? Okay, seeing no one else to testify, are there any questions for any of the, for staff or for any of the conferees? Senator Kirshen?
Did I get?
You're on, yeah.
Okay, yeah. Is there anybody from KDH&E still there?
Senator Kirshen, this is Ashley. I'm still here.
Okay, I don't know if this question, it's actually about Medicaid. A neighbor called me over the weekend and said they had put her mother in the nursing home, and her time had run out for private pay, and she had applied for Medicaid. And when she got the application, there was a voter registration form inside it. And is that a common practice, or is that just a fluke? That why would she get a voter registration application? And she is a registered voter now already. So she asked me how that happened. I said, I don't know. So any insight on that?
Senator, this is Sarah Fertig, the state Medicaid director. The power is out in my home as well, so I can't turn on my camera. I hope you can hear me. Yes, that is common practice. It's actually the National Voter Registration Act, a federal law that requires us to provide information and an opportunity to register to vote when somebody applies for Medicaid.
Okay, regardless if they're already registered?
Yes, we have to do that pretty much every time we receive an application. We have the Medicaid clearinghouse has no way of knowing immediately if someone's already registered to vote. It's just the federal law that requires us to do that with each application.
Sure. Okay, thank you very much. I appreciate it.
You bet.
Okay, so seeing no other questions, I think that we can, and there's anything else from staff to provide today?
I don't have anything else to provide, but I did send you and Senator Kirshen a link that links to all the testimony that was provided for today, both written and oral.
Thanks, Megan. I appreciate that. With that, we'll close the hearing on the KDHE budget. And I thank everybody for staff and for the presenters for their time. And with that, we're adjourned.
Good job, Pat. You did good.
Yeah, for my 5 minutes of fame. Yeah.
Thank you very much.
Thank you.